So it's fantastic to see so many members of the public. Hello, I'm Raj Jain, the Chair of the Integrated Care Board. Just to remind you, this is a meeting in public. It's not a public meeting. And whilst the public don't have any opportunity to ask the board questions today, we will find opportunities for people to engage with us. So thank you for that. Bit of housekeeping: if there is a fire alarm, it is real, and go out and onto the corridor. And for people speaking, will you make sure you speak into the microphones? Let's go into introductions. John, can I ask you to start?
Thanks, Chair. I'm John Llewellyn. I'm the Chief Digital Officer for NHS Cheshire and Merseyside.
Morning, everybody. I'm Warren Eskdale, Chief Executive of Voluntary Sector North West, and I work with the 14,500 voluntary community, faith and social enterprise groups in Cheshire and Merseyside.
Hello, I'm Fiona Lemons. I'm Deputy Medical Director.
Good morning, everybody. Councillor Paul Cummins, Partner Member Local Government and Cabinet Member for Adult Social Care and Sefton Council.
Good morning, Chris Moser. I'm the Chief People Officer.
Morning, I'm Paul Mavers. I'm the Team Manager at Health Watch Knowsley, but representing the Health Watchers for Cheshire and Merseyside area.
Good morning, I'm Claire Watson. I'm the Assistant Chief Executive.
Tony Foy, Non-Exec Director.
Hi, I'm Claire Wilson, Finance Director for the ICB.
I'm Steve Broomhead, Chief Executive, Winterborough Council, Partner Member.
Louise Murter, Corporate Governance Manager for the ICB.
Morning, Hilary Garrett, Non-Executive Director.
Graham Irwin, Chief Executive of the ICB.
Morning, I'm Alison Lee. I'm Director for Knowsley, so welcome.
Hello, I'm Chris Douglas. I'm the Director of Nursing and Care for the ICB.
Morning, I'm Anne Moore. I'm Chief Executive of South St Helens and Knowsley Hospitals and Southport and Ormskirk Hospitals and representing providers.
I'm Sarah McNulty. I'm Director of Public Health for Knowsley Council, and I'm here representing the Champs Public Health Network.
Good morning, everyone. My name's Adam Irvin. I'm a community pharmacist and I'm here as a primary care partner member.
Morning, everyone. I'm Naomi Rankin. I'm a GP, here as primary care partner member.
Good morning, I'm Neil Large, Non-Exec.
Good morning, everyone. My name's Anthony Middleton. I'm the Director of Performance and Planning.
Morning, everyone. I'm Rachel Jones. I'm the Chief Exec of One Knowsley, which is the CVS body in this borough.
Thank you. We've got a couple of apologies. One was from Dr. Rowan Pritchard-Jones and also Erica Morris, one of our non-execs. I just want to take this moment just to acknowledge and welcome two new board members, and that's Naomi and Hilary. Thank you for joining us. I've not been notified of any declarations of interest. Let me just double check. Is that correct? Thank you. Board action log. Sorry, missed one. Let's go back to the minutes. Any matters arising or accuracies of the minutes? Paul?
Thank you, Chair. Item ICB 012312, review of Liverpool Clinical Services. I don't think the minute there reflects what actually happened at the meeting when there were a number of representations from the public which made it difficult for yourself to conduct the meeting, and you actually suspended the meeting, which I think lasted for about 45 minutes. I think that should be reflected in the minutes. I find it quite strange. There was considerable interest from members of the public. Well, there was, but it was far more than that. And I think that should appear in the minutes, as I would like some reflection of the comments that I made about this being a very Liverpool-centric review and not involving local government outside of Liverpool City Council. I also mentioned that it was the report confused the Liverpool City region with Liverpool City as well, and I had a number of comments to make. So I think the minute needs to be altered to reflect the suspension of the meeting and also additional comments and concerns about the review that were made as well. I mean, the final resolution is is okay, but I think for accuracy's sake, it needs to be amended.
Thank you, Paul. I agree with those. Does anybody disagree with those comments? So let's reflect those in the minutes. Thank you. So can I take, with that caveat, can I take the minutes as being accurate? Agreed. Thank you. Board action log. It's there for noting. Any comments on the board action log? No. Okay, thank you. And the board decision log, again, for noting. People happy it's accurate, or any updates? Thank you. Let's go to the Chief Executive's report. Graham.
Chair, thank you. As you know, I use this report to bring forward a whole range of issues for the board's attention, and I'm going to start with an issue that isn't in the report, if you don't mind, and I'm going to comment further on industrial action, given we've talked about this at a number of meetings previously. And I think the first thing I want to say about the industrial action is for us to record our thanks to our service managers that work at every level of the NHS for how they have maintained good relationships with staff and trade unions throughout the industrial action days, but also how they've managed to maintain services as safely as possible during those strike days. However, I also wanted to note it isn't just the strike days, it is the consequences of not only the cancelled activity on those days that has to be subsequently caught up, but it is also the consequences of the changed behaviour from our public. Now, on one of the recent ambulance strike days, calls to 999 on that day were down by 9%. Now, you know, you cannot put off having a heart attack or a stroke. But if the public's behaviour changes, it changes in some regard because they realise that the NHS's service offer and provision on those days is different, but it is also a concern that there may have been a patient on one of those days who should have sought healthcare attention who didn't, and the consequences and the outcome for that patient will be worse as a result of waiting. It's therefore really pleasing, and I know this is the first step in a process, but it's really pleasing that the government and the RCN have commenced talks, and that has enabled the postponement of the escalated action that was going to take place. And of course, we also have to acknowledge that it is not just the escalation of activity by the RCN, but the fact that the BMA had voted for strike action amongst their junior doctors. So let's keep our fingers crossed that a resolution is coming shortly, so that we can get back to the business of doing the very best that we can for the population that we serve. And it would have been remiss of me not to acknowledge and mention that at the start of my report, Chair. There are a few items in the report that are for information and noting, and of course I'm happy to take questions or to defer those questions to members of my team. But one of the things that I wanted to also talk about today was in our January meeting, we talked significantly about the pressures being felt by the NHS through the winter period. And we always talk, don't we, about how A&E is doing. We always talk about people who are waiting for operations in our hospitals. And it was remiss of me not, therefore, to talk about the pressure that exists in other parts of our services. So I've sought to effectively put that right today. Now, in some regards, when we talk about pressures that exist within our services, it's the case that you might turn back and say to me, well, you know, don't come here and tell us about pressures and problems. Tell us what you as a board are doing about them. But there is something fundamentally important to acknowledge for our frontline staff and the people who manage those services, that we know that they work in a difficult operating environment at the moment, and we know that there are significant challenges to being able to deliver the type of care that they want their patients to receive, that we want their patients to receive. So just talking through mental health services, the problems in mental health services surrounding flow are very similar to the problems of our acute hospitals. If we are not good at discharging patients from our mental health beds into other settings, well then we don't have the opportunity to admit the next patient. If we don't have the opportunity to admit the next patient, quite often that next patient is waiting, or they're waiting inappropriately in a setting such as an A&E department. And in some of the worst case scenarios, they may even be waiting in police custody for access to mental health services. So really important to keep a watching brief on this, and that we understand those settings. We don't measure mental health services in the way that we measure some of our acute services. So I've tried to pick out today some of the key sentinel metrics that we do use to give an understanding of that. So one of the consequences of not having good flow and good availability of mental health services at the right place at the right time is patients get placed inappropriately out of area. Now, one of the things that we've put in here, and any of these measures are by comparison to other places. So we have said in the measure of patients who are inappropriately out of area, 20% of those patients in the northwest who are out of area belong to Cheshire and Merseyside. Well, just by comparison, we are about 36% of Cheshire and Merseyside. So for all those patients placed out of area, that's not acceptable. But actually we are doing slightly better than our immediate neighbours in that regard. It's also fair to point out that the issues here are not just issues of the health service, and this is one of the things that the ICB needs to bring to bear. This is one of the things that we need to be able to influence, because quite often somebody who has been in an inpatient setting for mental health services will not be returning to the place that they lived before they're admitted to hospital. And it can take a long time from the point where the discharge planning for those individuals has commenced to securing a tenancy, a place for them to live. And we need to get an awful lot better for that. And again, I also highlight the waits in accident emergency departments and give you a measure and a number for that. And where you see reference in this paragraph to Prometheus, that's a commercial service provider with whom we contract. So when a patient is with a mental health condition in an A&E department waiting to be transferred onwards, this is a specialist firm that come in and provide support to keep that individual safe, but also to make sure, as they're in an inappropriate setting, that they do not have an adverse impact on other patients around them. Similarly, talking about mental health services, I've also talked about general practice. One of the things that we are expecting from government in the very, very near future is something that I think they will be calling their primary care recovery plan, that will set out the expectations that the public have or could have of GP services. I know that will feature very heavily on that first point of access and contact. But as we look at this, it's really important to acknowledge how hard our general practices are working. The fact that they are delivering more than 110% of the activity levels that they were delivering pre-pandemic. Yes, an awful lot of that is now virtual or through new methods of access, but we know that the public do not experience the ability to access and have their healthcare needs met in a way that they would appreciate at this time. So again, to set the context, to acknowledge the pressures, also to acknowledge how effectively primary care changed. So in other times and other places, you will have heard how the NHS has had persistent campaigns for a number of years to reduce the prescribing of antibiotics, so that we do not get the resistance to antibiotics when we truly need them. Well, national policy was changed over the Christmas period because of the outbreaks of strep A. Well, the way that our general practice stood up, offered additional appointment slots to families with children, to babies, to reassure them, to change prescribing policy in very, very short order, really continues to show that the NHS, at the population's greatest hour of need, will always be there for them. But the pressure that put on the service was absolutely immense, and important that we acknowledge that. Chair, I'm not going to talk any more, except to say there are some issues that do need to be formally recorded, and we have brought forward items from subcommittees and other areas, including the noting of the establishment of some new subcommittees of the board. So happy to take questions on all, but would ask at the end that you just note where there are recommendations that those are recorded. Thank you.
Thanks, Graham. Before I ask for questions, I'm perhaps going to preempt. I could see Adam's face as we were talking about pressures in general practice. Really, really important to hear that. But primary care is wider than general practice. It would be really good if in future reports, Graham, we could hear about wider primary care. It's so essential to us. But Adam, did I steal your thunder?
You did a little bit. And actually, I do recognise the ICB has a very broad coverage. I think I welcome the pressure statement for some parts of primary care. It's not there for all yet. And I think there's a bigger point about visibility. I think on the banner, as people came in today, it says that we have multiple places where people access care, and it details them. We very rarely bring that visibility beyond the front door. I think since day one attending this meeting, I've been asking for performance reports for all of primary care, and we've not yet seen it to any great degree. There's a little bit creeped in this meeting's performance report, but not an awful lot. And I think what we're seeing with the resilience and the support mirrors that visibility. We had 592 pharmacies when we commenced as an ICB. That's printed on the banner. Today we've got 560. We are losing them because we're not supporting them and they're not financially viable. Some of that's national, some of that's local, but I think the way we talk about all of our various strands of care represents that.
Really good point. Yep, you're happy with that, Graham? Can I take any other questions or comments on Chief Executive report? Steve?
First of all, Graham, I welcome the report, and particularly the emphasis on system pressures, and to thank you for getting the social care discharge funding to local governments as quickly as you've done. That's really helped with bed capacity and access into hospitals. However, we still have an issue around admissions avoidance and investment in prevention. Unfortunately, the public health grant is only going to be increased in 23-24 by just over 3%, and we should actually be, I think, spending more money, investing more money in prevention and helping to reduce health inequalities. It'd be good if through CHAMPS, I think, at a future meeting, we could have a bit of a report on, where the funding for public health is now being invested and how it affects the whole of the system pressures that you've well described.
Did you want to make a comment on that, Graham?
That's fine.
Fine, okay. Any other questions or comments on Chief Exec's report? No. One question for me, perhaps for the future, Graham, is it'd be useful to have an understanding of the accountability that this board will take on board in the new financial year as the joint committees around specialist services is pulled together. It's just not clear to me in the narrative. And if we could come back to that perhaps next meeting.
Yeah. If we will come back to that, Chair, but just very briefly for today, some aspects of specialised service commissioning will be devolved to this board. Some other aspects of specialised commissioning will be devolved to this board, but because of scale, we will only be able to exercise that power by working in harmony with our neighbouring ICBs. And then there will be a third category of there are some aspects of specialised commissioning that can still only exist and will be maintained by NHS England, but they intend to invite us to join a committee with them so that we may influence it. So it's very complex. There'll be 3 layers to these joint arrangements, and we will bring a full report back to the board when we have concluded the due diligence and sorted out the transfer.
Thank you. Claire, did you want to come in?
It's just to say we need to bring the terms of reference of the joint committees back next month, because the joint committees will go live from April. But 23-24 will almost be sort of a shadow year, because we won't take on delegated responsibility until 24-25.
Thank you. Helpful. So, if we go to those matters that need formal recording, the decisions taken by the Executive Committee, and I think you said for us to note the proposed governance arrangements. People happy with those? Thank you. Alison, report of the Place-Based Director. Are you giving us a presentation?
Thank you. Thank you, Raj. I'm hoping my presentation will appear. Great, thank you. So whilst that's coming up, I'm really proud to be here today to talk to you about Knowsley, one of the 9 places of Cheshire Merseyside. So this is our place, and you are in Knowsley today. So a bit of an introduction to Knowsley. Given where we are in the year, a bit about what we've done since our inception in July, and also a bit of a forward look as to where we're going as a place. So quite a lot on some of these, but I will talk at a high level to them. So really importantly, our partnership in Knowsley is called Knowsley Healthier Together. So with partners, we have worked and got our values, which you can see echo those letters. So our values in Knowsley are kindness, honesty and trust, going back to that Knowsley Healthier Together partnership. We are trying to weave together within the borough 3 things really. One is looking at where the NHS is going. You'll remember the NHS long-term plan. The integrated care system strategy, which is all about giving everybody a great start in life and supporting people to live long and healthy lives, which we absolutely support as well. But as importantly for us as a borough, we've got our Knowsley 2030 strategy, which has been developed, led by the council, but with all partners, be that housing, be that industry, be that the NHS, be that education. And we play our part in making the borough thrive. And indeed, Tony, as a non-exec, and myself actually part of that board in Knowsley, really bringing all of those partners together. So that's our overall vision. Moving on to a bit of our bingo card, I guess, for Knowsley as a place, and not all of the facts and figures are on here, just a few of those to pick out. So we've got a resident population of 155,000, slightly more than that, about 170,000 registered with our GPs, and we're always trying to look at what that difference is and get to the bottom of that. We have 15 electoral wards, which you can see on the map there. Each of those have 3 councillors, many of whom I've got to know and work with since I've been in post. So we've got 45 elected members. We have 25 GP practices who work through 3 primary care networks. Our population largely use 2 main hospital trusts. There are 3 NHS trusts who provide our community services and 1 trust providing mental health services. So that's just a bit of a snapshot of some of the facts and figures of the borough. I may have some of that wrong. I'm listening to my colleagues over here. Maybe not, no. It keeps it simple, absolutely. So in terms of our population, I think it is a real positive that Knowsley as a borough is growing in population. So it's good. We've got a growth in population that perhaps wasn't there a few years ago, lots of new homes being built, but we obviously then have to make sure we have both the NHS and other infrastructure and architecture in place to support those new residents. But that's a good thing. We have got an increasing elderly population, again, like much of the rest of the country. But for Knowsley, when you will see in the briefing pack that's gone round to the board, we are the second most deprived borough in the country. When people grow into old age, we want them to grow well, but there's an underlying level of deprivation which adds to the complexity. We also know that the numbers of people over 65 is a really good proxy for workload in general practice. So as numbers of over 65 grow, the workload on our general practice and other primary care providers grows. It also 2/3 of our admissions to hospital are in older people. So that's a real focus for us, is looking ahead. We've had a 13% increase in older people. That's going up by about 25% over the next 10 years. So we've really got to remodel and focus on how all of us deliver our services to older people. That's really important to us in the borough there. So there are a couple of things to pick out there for you. Thank you. I'm not going to go through the next two slides because they have been circulated in advance, but I think you've seen those for most of the places. If Knowsley was a village of 100 people, some of the things we'd pick out, and also our health status across the life course, for all the way through from conception to birth, all the way through to old age and death. A couple of things that I will pick out there. I've talked already about the levels of deprivation. So 60% of our population live in areas that are categorised nationally as being the 20% most deprived. Also, I think behind this is to note, and Sarah, who's our Director of Public Health, will know this as well, that in the last 2 years, our life expectancy has decreased. So the consequence of austerity and COVID is that people are now not living as long in the borough, let alone living longer healthily. So that decreased by 2 years in Knowsley. So the health inequalities that I know you as a board really, really think about are absolutely writ large within our borough. So people are not living as long as they used to. So there's some of the things that we're having to tackle. And indeed, going on to the next slide, looking at our top health challenges, nearly all of those are around prevention and public health in its broadest sense. So how do we turn that life expectancy tide? How do we help people deal with depression? Lots of anxiety and depression in the borough, and if you're living with austerity again, that's becoming more and more obvious, the issues of mental health. High levels of smoking. We all know it's very easy to give up smoking, but it isn't. Not when your life is very complicated. Actually thinking, you know, do I want to give up cigarettes is probably the last thing on your agenda when you're thinking about, can I feed my child at the end of the day? Can I afford to put my lights on? So we know we've got to really think very innovatively about how we help people give up smoking. Obesity, similarly, the evidence base is clear about how to do that, but very tricky in the borough of Knowsley. Many people living with long-term conditions, and unsurprisingly, some of those long-term conditions that will be related to obesity and smoking are very prevalent within the borough. So heart disease, type 2 diabetes and respiratory condition. Also, we've talked about the ageing population. We know an underlying indicator there will be the numbers of people who live alone. We know loneliness and isolation is a really, really important factor about helping people to live a long, healthy life. So all of those are really our top key health challenges within the borough. Knowsley as a place then. So as I said, as a place-based partnership, Knowsley Healthier Together, we meet as a board every month. It is chaired by our local authority chief executive, who unfortunately can't be here today. He did want to be here with us, but can't. So although we meet as a board every month, we work together every day. I don't think there's a day goes by that I'm not working with one partner or other, and many of them are actually in the room, and that's really nice because I feel very supported in giving this presentation. So be that the third sector, be that Health Watch, be that the local authority, be that Mersey Care, who I can see in the audience, we work together every day, solving things down to individual patients stuck in hospital, and we'll be aware of that, or individual people with mental health problems, all the way through to dealing with some of those population health issues. We work together every day as those partners. So some of our achievements already in 22-23, and some of these predate me, they predate the ICB, but they're things that we've been working on. We do have historically really well-developed partnership working in the borough that I think is back to strength now. So we have got very big integrated budgets that are called Section 75s. So we agree to pool our budgets in many different services in Knowsley, and we're hoping to broaden that out to children next year. So that's focused on adults at the minute, but we're aiming to broaden that for children at the minute. We do have a real focus on home first. And interestingly, Knowsley does actually have a really high track record in getting people back to where they came from. We really try not to admit people to institutional care homes, but to provide support, care at home, through social care and the NHS as much as possible. And we do benchmark really well on that indicator. We've got a really good council in-house team that provides rapid response and reablement, again, to get people home as quickly as possible while we look at the wider home care packages that we need to commission. So that in-council service is a really, really important part. We've delivered the requirements of virtual wards and more of those virtual beds coming online. Some of you will have seen the really good BBC where they went out to somebody who was in Aintree Hospital, following them into the virtual ward. Really, I think, set out very clearly for the first time how virtual wards are working and helping our population of Knowsley. We've got some additional contracts with Liverpool Heart and Chest Hospital, and we're the lead place for that contract to support people at home who have heart disease and respiratory conditions. We've also been really fortunate to work with Merseyside this year to launch their Life Rooms concept, which is a remodelling of mental health recovery and delivering that on the high street, and particularly in Knowsley as it is in Liverpool, in libraries. So that was mobilised by Merseyside this year. There's lots of other stuff on that slide, but I wanted to pick that out. We're also very conscious as a borough that you can feel a tirade of bad news, and what we try and do is set out there is some really good stuff that the NHS and partners are doing, and every day we are trying to seek out that good news and tell that story. So the next slide, pardon me, is unrelentingly positive, and it picks out the things that we are delivering within the borough. So we are delivering the 8 minutes ambulance response time. So everybody who's categorised as having a life-threatening call, we are constantly meeting that target within the ambulance service. Our A&E attendances are actually down within the borough as, when we compare ourselves to the pre-pandemic levels. Some of that is because, and again, a bit of a plug, that was also on the news last night on ITV this time, were our walk-in centres. So our walk-in centre in Kirby was on the news last night, and that really helps take some of the pressure off general practice by offering an alternative, and that means we can see actually fewer people from Knowsley ending up in A&E at the moment. I wanted to pick that one out. Graham's already mentioned that GPs and their teams are seeing more people than they did before the pandemic, and all 25 GP practices in Knowsley are rated by CQC as good. They're also, with the partnership working with their pharmacy colleagues, we are one of the places that are actually doing the work that Graham talked about high-risk antibiotic prescribing, so making sure that we are limiting antibiotics when we need to, so that those of us who absolutely have to take it, it actually is able to treat as it should do. So doing well around antibiotic prescribing as well. I'm not going to do much here on our 2-hour urgent care response service because, spoilers, that's the patient story I want to talk to you about as well. But our urgent community 2-hour response service, again, integrated between the NHS and social care, is delivering really good response, and I'll tell you a bit about that more when we get to our resident story. How we're engaging our communities. We've had a good campaign over Christmas and the New Year. I've got a little example of it here. We got, I think, 15,000 of these leaflets out to our population, very much supported by Rachel from One Knowsley and Paul from Health Watch, to really say what are the local services that are available, what's the choice, what's the offer within Knowsley at the minute. We are starting our Northwood project. That's our most deprived ward within the borough, doing an asset-based approach, working with the people who live there, the organisations, the community groups, and saying, what is it that you think we need to be doing to improve your health? So not us going and telling them, but really listening to the people who live there and work there, and doing that asset-based approach to population health and community development. So working with public health colleagues on that, who've kindly put some money in to help that happen. And Paul is actually, around the table, going to be leading that project for us within the Northwood ward. So I'm really excited and want to come back and talk to the board about that. Relaunching our patient participation groups. I've got colleagues who used to work with me in West Cheshire in the audience. Really important that we get the patient participation groups in our GP practices relaunched. And finally on this one, working with our local authority on what we call the Knowsley offer. So with our partners, we've been out listening to our residents about what the NHS offers now and being clear what we will improve. The number one issue for our residents is access to general practice. And, you know, I noticed that's not a sentinel metric that we're talking about as an ICB at the minute, but that is the number one issue on the doorstep for our population, is how we improve access to GPs. So that will feature very strongly in our plan for next year. That's just some examples of the stuff that we've sent out just on one page for you there. Nearly there, Raj, I promise. Next slide, just setting out our governance arrangements so you can be clear how we as a board report both here to the Integrated Care Board and to the Council. So we report up through the Council, through Health and Wellbeing Board and scrutiny committees. Paul's already mentioned scrutiny committees. So they're really important to us that we account back to the population and our elected members as well as up through the NHS. So that's our sort of governance arrangements on a slide there. The revised offer, so again, having been out and listened to people, and I'm not going to go through the slide line by line, but these are the things that are really important to our population. It is access to GPs. Primary care is more than GPs, so we can talk about that. Pharmacists, physios, dentists, going to be really important for us to get right in the borough next year. Further expansion of hospital wards and hospital at home, supporting care at home, making sure people get the daily support they need. That is what social care is really about. And for me, all of those things is where place should be focused. So trying to pivot our attention away from all the hospital metrics, which are really important, but into these things that are going to make the difference. And someone's already said the importance of admission avoidance. These are the things that we can do to actually keep people fit and well at home, to make sure the hospitals are there when people really, really need them. So if we are going to change that model of care, our money, and change our patient experience, this is what Place has to focus on, and really hoping that you as a board will back that's the focus for us. And then the last slide is just another way really of setting that out. So we've got a real focus around starting well. One that I know we're going to be talking about more within the ICB is improving what's called the neurodevelopment pathway, helping children get the diagnosis they need, children with special educational needs. You can see amongst this there's some joint work we're doing across St Helens and Halton as three places working together. Primary care, unashamedly, absolutely our focus within the borough. All the things we can do to help with live well and ageing well into old age. And then the other thing I'll mention right at the end is as a Place team, we are taking a lead for estates across the whole of Cheshire and Mersey. We've agreed with Claire that our team within Knowsley will try and add some expertise and some leadership around estates across Cheshire and Mersey, as well as within the borough. So thank you. That's Knowsley. Thank you very much.
Thanks, Alison. Really interesting presentation. Some great stuff in there, and also an illustration of some of the challenges that you face. I think we're taking the resident story. I'm not sure how that's going to... Is that a presentation as well?
It's just a slide.
A slide.
It may be. If it is it on?
Just while we wait, just a clarification. You made a comment about sentinel indicators and GP access and the ICB. Sentinel, just for the members of the public, sentinel indicators are a subset of our priorities. GP access is most certainly one of our key things that we are looking at.
Thank you, that's helpful. I'll wait for the slide to come up. Oh, there it is. Well, sort of. So I'll talk to it. It probably isn't going to display very well on the screen. But when Graham was asking us to come up with a story from our residents or patients, and we were thinking about what to happen, I received an email from a colleague in the local authority that just to me told the story that I wanted to bring with you today. And it was really interesting that the person who both lives and works within the borough, and it is her quote that's at the bottom of the slide, which is, you know, I've always been extremely proud to live and work in Knowsley, and receiving a quality and critical service makes me even prouder. And I thought, oh, this person thinks it's a local authority service, and actually had to catch myself and say it doesn't matter, because it's a fully integrated service between the NHS and the local authority. And this is our urgent care to our response. So I'll tell you the story very briefly. So just before Christmas, the family hit a crisis point with a mum and dad, particularly the lady's mum, who's 78 years old and lives with Alzheimer's. She caught the cold, heavy cough and flu that many of us experienced around Christmas and New Year, wasn't eating at all, and her weight dropped to 5 stone, 8 pounds. The family were at a loss as to what to do and were worried that the only other option was to call 999. They didn't want to admit her to hospital because they knew how overwhelmed the NHS was, but more importantly, they feared that if she went to hospital, she wouldn't come home. And she wanted to be in familiar surroundings with familiar places. Our urgent community response and rapid response, part NHS, part local authority, working together, came out to assess both people, and I think that's really important. Her dad is 80 and has had a heart attack a few months ago, and they were concerned about him. And both those services, the daughter said, were absolutely amazing. They treated their mum and dad with compassion, with respect and dignity, as well as a lovely touch of humour thrown in as well. The doctor prescribed antibiotics for my mum to clear her infection, but she was unable to digest them and was rapidly deteriorating. Anne-Marie from the Urgent Community Response Team prescribed the same antibiotics but managed to get them in liquid form, as well as give both mum and dad full medical health checks. So we talk about making every contact count, and there's a really beautiful example of that. Anne-Marie gave us some really critical advice on the best way to care for my mum, which we followed to the letter. So there's an example about a trusted health professional. Somebody's listened to me, I'm going to listen to what they've told me to do. And she visited us over several days until my mum was in a more stable position. It was such a relief to have a medical professional give them a thorough health check. And we have no doubt whatsoever that the care and advice they provided not only kept my mum out of hospital, but we strongly feel that it saved us from losing her altogether. As a family, we would like to send our heartfelt thanks and gratitude to the Urgent Community Response Team. And I think that's that story there. And I think the next slide is just how we describe to our health professionals in Knowsley that urgent community response. But I think the words of the daughter probably tell that story much better than how we actually send out the stuff to our GPs and other staff who can refer into that service. So that was the resident story. Thank you.
Thanks, Alison. It's great to bring these things to life through that resident story and to hear about the community service. Thank you. Unless there are any pressing questions or comments for Alison, Neil?
I thought that was great, particularly showing your achievements and your ambitions. I suppose just a three-part question, just quickly if I can. One is, how has the creation of Place helped you in that, and what do you see the further opportunities are, and how can the ICB help you?
Thank you. So I think Place is Knowsley, isn't it? When we talk about Place, we mean the borough. And what I think has really helped is the partnership. And I think when I came into Knowsley, and I felt almost like I was kind of on my own, it was the local authority that I gravitated to immediately. So I think the strength of that relationship with the local authority, not only social care and public health, but all the directorates of the local authority have been absolutely crucial. And then building from that, the relationship, Knowsley's small, so it's only got 3 primary care networks. So being able to have all 3 primary care networks around the table is really important. having the single way into the voluntary sector through One Knowsley, having Paul and Health Watch with us, and then having our NHS providers, St Helens, Merseyside and Wirral, because Wirral provide our 0 to 25 services, interestingly, as well as Liverpool around the table, has been really, really important. So I think the reason that some of this is done is that we do, as I say, we just work every day in partnership. I don't think there's anything that I can solve on my own, just as the ICB. So what can the ICB do? Well, you know, I am the ICB, I'm part of the leadership team of that, and every week I work with my ICB colleagues and solving some of this as well, you know, with all the director colleagues around the table. I think one of the things that I would ask is that we are freed as place to deliver what I've talked about today, whereas I feel all the time we're being pulled back into sorting out delayed discharges. You've got, you know, this is what's going to make the difference, and so that move from that transactional stuff to the transformation is freeing up the time to do that. I think is that's what I need.
Yeah, I think we feel that we felt the establishment and the governance and the setting up's been important, and I think we're all ambitious to move on to that next phase, aren't we?
We are, absolutely. Steve?
Just in relation to financial delegation, I think we agreed a working principle here of 80% to place, 20% kept in the centre of the ICB. Are you content with the way that process is moving forward?
Yeah, I mean, it hasn't come yet, has it? And that's the reason, I guess, I wanted to show the governance slide. And I think as a place partnership, we're going to have to be able to do at least 2 things. I think I talk about it as 3 things. We're going to have to do all the transformation stuff. We're going to have the oversight of the joint budgets I have with the local authorities, so we're looking at Sarah over there, and also be responsible for what is delegated to us by the ICB. So there's almost 3 things we're going to have to do as a partnership. I think the direction of travel is right. I think the way that Claire, as Director of Finance, is setting out what is being delegated to place, I mean, the reality is that a lot of the finances for next year are going to be tied up in NHS contracts. We're not a lot to move on that. I want to make sure that my residents get their fair share of the elective care programme, for example, because health inequalities, again, we may not be getting as much of that. But I think it's the contracts outside of that, with the voluntary sector, with some of the smaller contracts we hold in the borough, that we can really, that's where I want to focus next year. So I'm happy with the way that's going, Stephen. Yeah.
Thank you. Any further questions? Well, once again, thanks for the great presentation, Alison, and your comments and responses to the questions that were being asked. It's really insightful. Thank you. Okay, should we move on to the Executive Director of Nurse and Care Update Report? Chris?
Thank you, Chairman. So the report provides the board with an overview of the current risks and issues relating to quality and safety within the system of Cheshire and Merseyside. And the report this month features a number of items, but I'd like to draw the board's attention to a few of them. The system oversight framework provides a segment rating for each provider trust within the system. And the board have previously been informed regarding Cheshire and Wirral Partnership Foundation Trust and the current work in regards of challenges that the trust face. Following a recent segmentation modernisation exercise that has been conducted in line with the NHS oversight framework, and there was a focus review. And following this review, a decision was taken to move the trust from segment 1 to 2. NHS England and the ICB will continue to support the trust and work collaboratively to progress towards a segment 1 rating. I've previously mentioned to the board about being successful in securing an additional £330,000 funding from Health Education England to develop a programme of education for those nurses who currently work in the residential care and nursing care sector. And the monies have to be spent on supporting interventions that help avoid admission and aid discharges from our acute hospital settings. We have secured support from one of our local higher education institutions of a mobile training facility and a skills hub, which is including access to a digital tour bus for up to 2 days per week. and this is equipped with virtual reality equipment and will work one-to-one with staff. And I'm sure you'll agree that this is an ideal way for staff to learn, where we take the training to the learner in their place of work. And I'll bring back some further updates on how that's developing in my future report. And finally, I wanted to share with the board that through a bidding process, we've been successfully chosen as one of the 3 ICBs in the country to work with Barnardo's and the Institute of Health Equity, which is led by Sir Michael Marmot. And this is to shape the way that ICSs create health and address health inequalities amongst our children and young people. The programme's designed to develop a children and young people's health equity framework. And as you'll see from the report, there are a range of benefits. For example, a better understanding of local gaps and needs, and addressing childhood inequalities, but also the opportunity to be part of a dynamic partnership that will position ICSs at the vanguard of change, and also to work along Sir Michael Marmot. So further updates will be brought to the ICB in due course about the progress of being part of that board. And that was all I wanted to highlight, Chairman, but happy to take any questions. Thank you.
Thanks, Chris. Any questions, comments? Hilary?
Thanks, Chris. Great news, isn't it? And well done securing all those resources. The training for the residential registered nurses, I presume, is that going to be targeted into areas where we've got the most challenge? And I suppose, just to conclude, I suppose this is a great opportunity for us to show return on investment as well.
So we have an identified lead for the social care sector in respect of nursing employed within those areas of work. And we're linking quite closely with the individual who has a forum for representation across the Cheshire and Merseyside system of nurses employed within that care sector. Yeah. So we're working quite closely. We're also, we've had discussions through our system quality group around where best to target our attentions on that. Yeah. Obviously, the money is not going to go across the whole system.
Exactly,
but this would be an opportunity for us to test this method of training and learning, and then hopefully future we will be able to spread that even further.
Brilliant, because our domiciliary care settings would be also really good ground, wouldn't it, to expand the skill set. And just finally, I think that health equity collaborative is something completely support, and particularly helping us understand, you know, the impact of early childhood trauma, so become more trauma informed, not just as individuals but as a system and at places as well. So I think that I really welcome that, but highlight that particular aim in respect to that particular aim. Thank you. Thanks.
Thanks, Hilary. Thank you, Chris. So the recommendation is to note the content of the report and request any additional information. Comfortable, we'll move on to the finance report. Claire.
Thanks, Chair. I will summarise the position at month 10, and then I'll just draw out 2 things, if that's okay, and then I'll open it up to questions. So at month 10, we reported a financial position across the system of a deficit of £63 million, which was a variance to where we'd expected to be at this point in time of just short of 30 million. We are still forecasting that we'll deliver our financial plan of a £30 million deficit by the end of the year. And this month, organisations have taken the opportunity to formally reset their forecast. We have a number of organisations that have been able to improve their forecast for various reasons, which are set out in the paper. And alongside that, we've negotiated with other organisations that have had to depart from their forecast and report an adverse variance, and we've done that this month. And as you may know from previous conversations, those forecast changes have had to happen together because of the National Protocol on Forecast Movement. So those numbers now are reflected in this report. There are clearly a lot of work to do in the final 2 months of the year in terms of delivering cost improvement programmes and also transacting some of the non-recurrent or transactional elements of delivering the plan this year, which organisations will be working on over the next couple of weeks, which is what will take us from our current deficit into the planned deficit of 30 million by the end of the year. You'll notice that there is a positive variance in the provider sector forecast to the end of the year of 7 million and a negative variance on the ICB position of 7 million, which obviously offset one another, and that is a result of a transfer of an improvement target that the ICB took in its own books in the planning process, but which has now been resolved across the system as expected. So the thing that I just wanted to pull out, I was going to just point to section 9, which describes the new forecasts from each organisation, as I say, under that coordinated approach that we've run across Cheshire and Merseyside. And then one other thing to point out is that in sections 21, we describe the capital programme for the system and the individual provider capital forecasts. You'll see in the appendix that talks about the detail of this that we have spent on capital across our organisations £112 million in the year to date, and we're expecting to spend 220 million by the end of the year. So 112 million in 10 months with the final 110 million to spend in the final 2 months is a very tall order, and it's very important that we deliver that. We do lose the resource if we don't. This profile is not unusual. We do have this spend profile in the NHS every year, but I thought it was just worth drawing that to your attention, because what generally will happen is that any accruals or work in progress may not be properly reflected in an organisation's positions until the end of the year, but nonetheless it is a reflection of some risk and the amount of work that's going on to deliver our capital projects across the system in the final 2 months of the year. And I'll leave it there, Chair. Thanks, and open to questions.
Thank you, Claire. Any questions or comments? Neil and Claire.
I'll make a comment. I think that's great. I think we're moving in the right direction. I think my theme is we've raised before that the NHS works on an annualised financial basis, and so this is tactical. Next year's plans will be tactical. It's about having that underlying longer-term strategy that we understand the financial positions and causes of deficits, so we can focus on proper underlying recovery rather than annualised tactical solutions. But great results so far, so well done.
Thank you. Claire and Tony.
Thanks, Claire. I know that primary care capital comes down a different stream, but if there's trouble spending other capital, is there an opportunity to vie between the two budget streams? Because I know in terms of wider primary care and general practice in particular, there are a lot of capital pressures.
Yeah, I mean, the underspend is certainly not a reflection of the level of it doesn't reflect the fact there is no need in the acute sector. I think, or the NHS provider sector, I think it's the ability to pursue significant works over the winter period in hospitals that have got lots of pressures. So there's only so much building work that you can do, for example, in a live hospital environment. So you do end up sort of phasing some of that towards the back end of the spring. I mean, technically we do have the opportunity to vie between all sectors, but we have been over the last, on a monthly basis since the beginning of the year, tracking this really, really carefully with provider organisations, and we are, we're absolutely, every single one of them is confident of delivering their plan that they are currently forecasting, albeit it's very ambitious, but they are confident. And any area where there has been a marginal underspend expected because of a slippage on a scheme or something, we've moved that already between providers, so we've been able to bring something forward from next year into this year, but it's at the hundreds of thousands rather than the millions. But we have had assurances from every provider that they will deliver the plan that they're currently forecasting.
Okay, I was just going to say, because primary care, hundreds of thousands is a lot in primary care, and in terms of improvement grant funding, we put a proposal in for considerably more than we received. So I suppose it's just if there are any opportunities, it would be, I think, well received.
Yeah,
thank you.
We'll bear that in mind. Thank you.
Good point, Claire. Thank you. Tony?
Thanks, Claire. In the body of the report, you refer to provider agency costs, and you set out some figures there that the spend is more than it ought to be, because we're tasked with reducing the reliance on agency staff year on year. Can you give us a sense in that paragraph 15 and 16 whether the trend is positive or whether it's continuing to be a significant challenge?
I think, and there's probably a number of people around the table who have different perspectives on this actually. My perspective is that it continues to be a significant challenge. I think there are some organisations that have really turned the curve on this over the last 12 months, and I think Southport and Ormskirk Trust, for example, stands out in that it is spending a fair amount less this year than it spent last year, and it's probably one of the only organisations that is. But the recent industrial action across the NHS over the winter period has definitely added to the pressure being faced on this particular budget. And you know, the targets that the NHS has been set in the planning guidance for next year are even more ambitious around reduction on agency reliance and the shift in moving towards using bank instead and really recruiting through our substantive vacancies, which is something that we are picking up as part of the planning process. But I think, in summary, still a significant challenge and has been made worse over the recent months because of the industrial action. But others might have a view on that from a nursing or a HR or a provider perspective.
Chris, want to give you?
Yes, thanks, Chair. So I absolutely agree with Claire. I think it is a really challenging area. There are a number of areas that we monitor around this. So those trusts that are exceeding the agreed price caps, those that are using agency that are off framework, and we do a detailed analysis of actually which of the disciplines we're seeing greatest agency use, and obviously then triangulate that with, from a quality perspective, where that means we've got fragile services or the quality can be impacted because of the sheer number of agency staff. As Claire said, we're doing some work looking at how we move from that dependency on agency staff to bank staff, but also making sure that where possible we allow people to move into substantive roles. We recognise there's also been a big challenge this year with the cost of living, and therefore we have seen, particularly in some parts of our patch, a move from substantive posts into agency work. Whilst we accept that's a short-term measure for some people, it has meant that they've been able to increase their income. So we are monitoring that on a monthly basis and work closely with trusts.
Thank you, Chris.
I can't echo what Chris has just said in terms of when you get a more stable workforce and a more stable working environment, you know, it does aid substantive recruitment. So, you know, the secret of Southport and Ormskirk's success in this field has been the opportunities we've taken to try and stabilise some of their fragile services and with a greater size of organisation be able to recruit staff because the rotas aren't so much of a disincentive. We know there used to be very small rotas with people covering, you know, 24-hour services with 2 people on a rota or something. Well, when you've got a bigger organisation, you can cover that in a better way. So one of the things we've been able to do, I have to say to Claire Wilson, much more from a qualitative point of view than a financial point of view. So we've got the benefit of the better quality that's provided by being able to recruit substantive staff, but also it does have a financial benefit as well, which is also a good thing.
Thank you, Anne. Great example. So if no further questions on the finance report, we consider the recommendation is to note the contents of the report. What we've heard, you know, is whilst we have some assurance, I think, Claire, is what I'm really hearing, there is still a good degree of risk before we hit the end of the financial year on plan. And if I could just, Chris, when we come back to workforce in future months, it'd be really good to have a bit of more of an in-depth understanding of the non-contracted staff issue. I'll put it in those terms. Fantastic, thank you. If we could move on to the quality and performance report.
Thank you, Chairman. Just conscious of the earlier input by Graham, I think, which was really excellent in terms of some of the other sectors that we tend to concentrate on in this report. And also similarly the input by Alison, which I thought was really good, bringing that right down to a local level really at Knowsley. I'll concentrate on just a couple of issues really and let the report speak for itself. So, you know, in terms of where we sit in February, we talk a lot about the urgent care pressures and as I previously reported to the board, the way in which we have visibility of that on a daily basis is that each system, it is actually the trust that submits it, but it's reflective of the overall system pressures, submits an escalation level. And during January, we saw systems consistently reporting at levels at the highest marker of that, which is an Opal 4 rating. During February, that has somewhat abated, and we haven't had any instances of a system reporting Opal 4, but there has been a consistent rating of 3 across all of our systems at present, and we shouldn't underestimate that. Opal 3 is still defined as the local health and social care system experiencing major pressures. As you're aware, and we talked about at the last month's board, there was a tactical response during January to the release of additional fundings nationally, particularly to try and support additional social care provision. And Cheshire and Mersey received just under £10 million to that effect. That has been deployed, and we do have a degree of confidence that that 10 million will be fully utilised before the end of the year. And it is producing some tangible benefit. We recognise it's just a small part of the overall focus and overall resource, but it has proved beneficial in some systems. And when I say some systems, I think that's because in some cases the market is really, really stretched. So we have seen areas of Cheshire that were able to mobilise more of a response than maybe the city of Liverpool, where that market has really been struggling in terms of financial viability. But nevertheless, it is impacting, and providers and other providers alike, trusts and other providers alike are reporting that they are seeing the benefit, and we can see the numbers of patients that are being discharged via that route on a daily basis now. There's obviously lessons to be learnt around what we've experienced during that highly pressurised period of January and still incurring. And as we talked last month, we are doing a winter debrief, which will take into account some of that learning, some of the stuff that was also brought through at Quality and Performance Committee from our ambulance colleagues. And the intent is that we will complete that debrief by the end of March and be able to report back to the board in April on that. In terms of elective, yes, we are still on track, as Orlo has highlighted in Graham's report, for the elimination of waits over 78 weeks across Cheshire and Mersey. We do recognise there's an impact of industrial action, and everyone within the ICB and the system absolutely recognises the issues of that action. But it does add a further challenge in terms of trying to recover that lost activity. But nevertheless, that is being achieved so far, and we do have that degree of confidence that 78 weeks will be achieved by the end of March. It is taking a lot of micromanagement by an awful lot of staff, but it is the right thing to do, and we should achieve that objective. So I'll pause there if it's okay, Chairman. I'm quite happy to cover any parts of the topic, or indeed some of my clinical colleagues may wish to come in on some of the other component parts, such as cancer, for instance.
Thanks, Chair. I think it'd be remiss of me not to comment, really, as we're in a public session, that this is a system in constant crisis now, and the problems with ambulances that Tony Anthony referred to there, and handover times, the problems with A&E, patients being treated on corridors. It's an absolutely awful situation. But what I want to reflect, and it was mentioned at the Quality and Performance meeting last week, is the impact on staff. And I think as an ICB, we should be making some sort of statement about understanding the levels of stress that our staff are under at the moment, and really that we have that desire to support them in every way. And it isn't just the NHS, it is social care as well. I do resent the term market. I don't think it should be a market situation. We're not talking about commodities, we're talking about people's lives. So that's just a personal view, but it really is a terrible situation that we're in. I really look forward to the day when we can see performance improving and quality of people's lives, but also workforce improvements, as I know that we have that desire to achieve. So I think these problems aren't brought about by the creation of this ICB. They go down to to Westminster, and that's where they're being created. And I think the sooner changes there are made, the better. But that's, of course, another personal view. But it really is a difficult time, and I want to express the sympathy I've got with and empathy with staff at this time, under a great deal of stress.
Thanks, Paul. So perhaps, in addition to what we know will be happening in each organisation, each primary care practice, about the leaders thanking their staff for their pressure, if perhaps Graham, through you, if we could seek to understand how we as an ICB board would follow through on that. We'd come to Graham, then Tony.
Anthony, I'm looking at page 113 of the pack, just so you know where you are. Now, one of the things that bothers me is we present a huge amount of information. That's an indication to people that on any given day we could be measured on hundreds and hundreds of different things. It's really important that we present the information to you in its raw sense, that we don't qualify that. But I just want to qualify one of the things on there. So if I look on page 113, it would appear that we've put a graph next to that statistic that effectively says we are the worst in the country, because where we have those little stacked bar charts on the right-hand side, that's us compared with the other 41 ICBs. Well, first of all, if it is a measure that is measured by volume, and volume alone, we are the second largest ICB in the country. So a normal result would be for us to come second on the left-hand end of that graph. So we just need to be careful how we think about that. But we also need to think about the fact that we're saying the number of people who are delayed in our A&E departments, or it takes 12 hours in their A&E department from the point where they're either admitted onto a hospital bed or discharged, is quite alarming. One of the reasons though we have that statistic is we achieve quicker ambulance handover responses than most other parts of the country, which means, you know, the ambulance is back on the road, and the patient who is the biggest risk is the patient that the ambulance service hasn't got to yet. But this isn't a little speech. Within this, there becomes a kind of question, Anthony. I think what we need to move on to now, from just recording our performance, is picking out 3 or 4 of the sentinel measures and starting to describe what we are doing about it. And what we are doing about it is something that probably needs to be considered in a number of places within the organisation before it reports back to the board. So, for how many of these measures have we considered it to be of sufficient concern that we have put in place some form of escalation and some form of recovery action plan? Who is monitoring? Who is overseeing that? So I don't necessarily want you to answer that today, but I want you to think about that in terms of how we're going to answer that and assure the board about that in the future. And I just use that delays to admission as a kind of metric to illustrate that point.
Thank you, Graham. Tony?
Thanks. And as ever, Anthony's report is extremely thorough and well rehearsed at Quality and Performance Committee, but the last Quality and Performance Committee, Anthony and I have both agreed, we heard more often that the answer is the system rather than an individual provider or an individual place. So what's emerging is, rather than trying to tackle, for example, corridor weights on their own, it's quite clearly not the right way to do it. It's the whole system. So the work we did on the urgent care system and looking at in the round, the gap we identified was, as I mentioned at the last meeting, was the impact of social care availability. So only when we triangulate all of the available data are we likely to come up with an answer that, as Graham was suggesting, that we need to focus on what we need to change and how. I think the general consensus at Quality Performance Committee is we'll always be changing it as a system approach rather than individual providers or places. So I think there's a successful change in culture there that's happened quite quickly in the committee. Thank you.
Thanks, Tony. Neil?
Yeah, Graham's finished the first part of my question, really, because it's a great report. There's a lot of information, but what's important and what should we focus on? And with that, I'm just thinking in terms of next year's plans, like when we look at the Trust key performance indicators, we always look back at the last 12 months. It would be good to look forward and have a trajectory of when we think they might meet those. Because it's no good holding them to targets we know they're not going to deliver if that's the case. So I think a trajectory would also be helpful for each. I know a lot of work, I'm sorry, but it would make it more realistic as to, are we monitoring something that's never going to be achieved, or where are we going to get to by the year end, perhaps, something like that.
Yeah. Thank you. Any other questions or comments? Anne?
Yeah, listening to all this, I mean, the metric ingredient is the bed occupancy level. Because as hospitals approach 100% bed occupancy, which is where we are now in some places, well above 100% occupancy, i.e. there are more patients in the hospital who have been admitted than there are beds to put the patients in. All bad things come from that. That is that we hold up ambulances outside. When we hold up ambulances outside, even though we do quite well at that, we still hold them up longer than we'd like to. That keeps ambulances off the road and not picking patients up who need to be given that care. It means we've got corridor care because we've got nowhere to put the patients. It means we've got a terrible experience for patients. We've got a terrible experience for staff. But it also, the other important thing is it does affect on the elective waiting list, because if there's no beds to do the surgery in, then there are a whole host of patients who need to have the surgery performed on the hot acute site, and we can't do those either, and they're often the people who we most need to be treating. So everything goes wrong when the bed occupancy is too high. So if there was one thing, when Graham just challenged Anthony to come up with something, that's the one thing that would make really the most difference to all of those things that we're talking about in terms of what would make it a better place to be in an acute trust right now, would be if some of that could just be decompressed, because it really is much too busy right now.
Thanks, Anne. Really helpful. Fiona?
Thank you, Anthony. Question for Anthony, please. Page 127 on your primary care dashboard, you've got the percentage of 2-hour urgent community response referrals where care was provided within 2 hours, and that's green, and that's great. Do we know how many referrals were rejected because the service was at capacity? Because that, I think, is the experience that GPs have quite often when they refer. And you might not know the answer just now, but we should think about it.
Yeah, I think you're absolutely right. I mean, certainly there are certain parts of the system that we're able to capture that. I can think of things where GPs seek advice from acute sectors. That's recorded when there isn't the response. I think the simple answer to that one is no, we haven't got the data just yet. But as we move towards probably some of the stuff that Alison highlighted early on about the improvements that we're making to primary care, some of that is about the access to primary care, not necessarily in terms of seeing the patient in front of a clinician. It's about understanding the true capacity by having increased digital and telemetry understanding. So similarly, we don't know how many people ring GP practices and aren't able to get a response. But those digital solutions will allow us to shed some light on that.
Thank you. Hilary?
Yeah, I'm sat here thinking about virtual wards. Are we using them to full capacity? Because I know nationally there are some issues with clinical confidence, with underutilisation. So I suppose that's one practical thing to look at. And secondly, have we got them in the right places? So I'm sure there's loads of data in terms of segmenting the reasons for admissions. And then the third thing is the predictions. When we get the next wave of COVID, whatever cycle we're on, whether it's every 2, 3 months, 4 months, are we prepared for that? And are we doing enough with the public, including ourselves, to keep ourselves well in terms of all the things we do in terms of prevention for respiratory contacts? So,
should we ask Fiona to talk about virtual wards? And
thank you,
Anthony.
Thank you. Excellent questions, and happy to have a more detailed bring you up to speed on where we are with virtual wards outside of this meeting. But from a highlight perspective, on paper, our utilisation of the virtual wards is 40 to 50% currently, but that includes virtual wards that have literally just come online and gone live in the last 2 or 3 weeks. So our utilisation has fluctuated. Our trajectory for all of our beds coming online is we're on target for the establishment, but that may affect utilisation because of what you've highlighted, that clinical confidence. But we have established clinical advisory groups. We've got an excellent comms plan to go out and support clinicians to help them to start using it with confidence. I think we do have them in the right place. We're seeing a mixture of acute respiratory wards for step down and frailty for step up, and heart failure, which is both step up and step down.
Thanks, Fiona.
Preparation.
Yeah, and as you say, I think, you know, we are seeing that cyclical pattern now with COVID, aren't we? Much more stronger. And we've got a good understanding of the impact both in community prevalence, but then also it manifests itself within the acute sector. So we are doing some work with our public health colleagues to try and tie that up. But there's definitely more ground to cover on that.
Thanks. Sorry, no.
So I was just looking at, again, page 127. I just wonder whether it'd be worthwhile, or if we'd be able to separate out the number of general practice appointments per 10,000, whether actually we can look at appointments with GPs, with nurses and with allied healthcare professionals. I think that would give us a better idea of the actual appointments being seen in primary care, but also whether it's possible to look at the number of appointments within pharmacy as well, so care of the chemist or referrals to the community pharmacy service. I just think I think the table would give us a better idea of the impact of on primary care as a whole.
Yeah, I think you're absolutely right. You know, that's probably been recognised for a while, that we need to get into that visibility for boards. There is work taking place underneath, outside of that. The real issue which we can talk to outside of here is obviously the provision of that data by those providers and the way in which we can aggregate it in a consistent manner so that we can present it and be meaningful. But quite happy to pick that up with yourself and Adam, as we've already done in terms of community pharmacy also.
Thank you. Adam?
Yeah, and we have done some work historically. Naomi and I just got our heads together and said, actually, there's some things we can do with this report. And actually, in the meantime, between the sort of the data lag of a provider element, there's some nationally published data that we can refer to that would give the board a better flavour of what activity is happening. So I think I've got some ideas, and if it's okay, I'll go direct with Anthony to try and develop that a little bit.
Thanks, Adam. Claire?
Just to give the board assurance that we do have quite detailed discussions at System Primary Care Committee about some of the sort of particularly the GP information per place on some of this. So we have got that information if you want to see it.
Thank you, Claire. Further questions? Let me just make a couple of comments. So it's really about the accountability of this board. So I think we've heard today, you know, Graham's point and people wanting more visibility of information. The pack is developed remarkably well over the months that we've been in post. So I know, Anthony, you've led that too, but it's been a team effort, so thank you very much for that. You also launched an electronic version of this, and remiss of me, I've not looked at it for months, so this may well be answered by that. But it's going to be important, I think, for our board members to be able to delve deep when they want to. It doesn't have to come in this report, but when they want to, your question, you should be able to just look into an electronic system to look at the data that you're particularly interested in. So there's that one point about the board's visibility and the ease of access. If we could just refresh our understanding of the electronic system, because I'm not sure how many board members do use that. The second one is illustrated by the information that's in front of us. Taken in isolation, there are some concerning data points in this. I'll use that phrase, and I'll do it across sectors. So you can see primary care, you know, the effectiveness or the compliance with diabetes management and hypertension. really low levels. Into national programmes, about screening programmes, you know, the breast one, I think I heard it on the news just recently, the low level of compliance with breast screening from the populations here. You can see for the acute sector, you know, hip fractures, 33% compliance with, you know, a bundle of activities that we know would be interventions that we know is vital to successful outcomes. So concerning information, we've got the Quality and Performance Committee who have the remit to look through this and escalate to board issues that should be brought to board's attention. And I'm sure a lot of that is happening. I think we have to think through and get tighter on the board being assured that these matters are being looked at in the most appropriate way. Graham, along with your ask of Anthony, I think that's a puzzle that we would look to Chief Exec and Exec team to think through about how we manage that, of course, with the support from our non-execs. Okay, so good discussion. Once again, thank you very much for the continuing development of this hugely important report. And it was there for noting and discussion. So, if we go on to the next agenda item, which is the EDI report, I think headed by...
I'm going to start and then hand over to Chris. Yeah. So, thank you. As you can see in the opening paragraph of the executive summary, the ICB has responsibility for paying due regard to the Public Sector Equality Duty Act. The equality duty is supported by specific duties set out in regulations that came into force in 2011. So it sets out there the responsibility of the ICB. Appendix 1 in the report is our 22-23 annual EDI report. It includes headline equality information activity that's taken place since the inception of the ICB, available and proportionate equality information, our proposed preliminary Year 1 equality objectives, and it highlights information about the EDS system. The board is asked to remember that the annual report provides the overview from the work since the inception up to February 2023, up to now. The paper builds on the report that was received in November, which outlined our approach to Equality Delivery System 2022. Section 2 of today's board report outlines our statutory, regulatory and compliance-related responsibilities for the EDI agenda. And I think it's really important that we all hold up a mirror to how we work in an inclusive and fair way and hold ourselves to account. NHS England introduced a new EDS, Equality Diversity Systems 2022 toolkit, which covers 11 outcomes spread across 3 domains. So the domains are Domain 1, Commissioned and Provider Services, Domain 2, Workforce Health and Wellbeing, Domain 3, Inclusive Leadership. Our current rating for Domain 1, Commissioned and Provider Services, is achieving. So this is the mode rating taken from the 11 provider organisations, their individual service review ratings that have been implemented through the toolkit. They're the 11 that volunteered to undertake early implementation. Domains 2 and 3 are linked to the staff survey. The gradings and survey report will be coming to, I think, April's board meeting, so we can have a wider discussion around workforce, health and wellbeing and inclusive leadership. We're proposing 1-year equality objectives detailed in section 4 to support our commissioning and system-wide organisational development. We know that the system and the ICB will mature during 23-24 to enable us to agree longer-term objectives for 24-25 onwards. We're keen to ensure the 23-24 objectives underpin our work and are a golden thread through the business because of the importance of this agenda. And I'm happy to have a conversation with the board and welcome comments on the proposed objectives. I'm going to hand over to Chris now to talk through our EDI work with the workforce.
Thank you, Claire. I think it's important to say, as Claire mentioned, there are 3 components of 3 domains in the EDS 2022. And the workforce, health and wellbeing and inclusive leadership. It is really important that we take not only our sort of organisational assessment but the staff feedback on that, and therefore it is really important that when the staff survey results are published on the 9th of March that we use that data to triangulate the data that we receive from organisations. That will also be the first time that we have a view from our own staff in terms of how they believe that we are working towards the EDS standards. But in terms of the responsibility for our workforce, we are required to publish data on a number of things. I'm sure many of you this morning will have heard that nationally the gender pay gap report has been released. We will be reporting on that. We are now large enough to do that, so it's for all organisations that employ more than 250 staff. So obviously some of our CCG colleagues didn't report on that before. So when we report on that in 2023, that will be the first time as this organisation. We're also required to report under the Workforce Race Equality Standard, affectionately known as the RES, and the Workforce Disability Equality Statement, which is known as the WDES. I'm sure that's not phonically correct. But, so the RES data will be collected in August, and it's published with an associated action plan. And I think the action plan is the absolute minimum that this board can expect to see regarding that. We'll report that in October. And in the report, you'll see some details of the key components of that report. The National RES report for 2022 was published this week. That was received yesterday by NHS organisations. And whilst there's lots of positive actions, it covers a period 2016 to 2022, it is clear that there's significant amount of work that still has to be done. But we have seen some improvements. It's important, again, that we build on that. The word DES data is currently mandated for NHS trusts and foundation trusts, so it isn't mandated for ourselves. However, in line with our commitment to best practice beyond compliance, it is our intention that we will report on that for the ICB as an organisation, and therefore we'll look to review our workforce disability data during this year, and we'll also publish that with our associated action plan. We've included some data on the gender pay differences in the report. That's the legacy CCG data where it was available to us. However, this was going to be refreshed, and obviously we're doing a big data cleanse in terms of all of the information that we have on staff, and therefore we will make sure that that is published on our public website. Very conscious that the paper today gives you a huge amount of data, and therefore don't intend to go through that. But both Claire and I and our respective teams would be happy to take any questions and to do any briefings that are needed outside of this board. So I'm happy to leave it, Chair, but happy to take any questions.
Thanks, Claire and Chris. Any questions and comments on this paper? Graham?
Thank you for this. And I know these things come in a kind of standardised format. But I'd like to see a little bit of context set for this. So if we go back to, first of all, what I would call the moral case for this. Well, the moral case is if the staff we employ are not representative of the populations that we serve, then there is a danger that the populations that we serve will not think that these services are for them, we will not get good access, and will not get the right kind of health take-up. There's, of course, the business case. If we're not able to employ people from the populations that we serve, in the long term, we would eventually run out of the ability to recruit staff. So what I see here is I see us comparing ourselves with the England average. I see us comparing the ICB with our NHS trusts in the area, but what I don't see is the context for the population that we're serving.
Thank you, Graham.
Do you want me to respond to that? I think you're absolutely right, and what we've got to do this year is report against the national standards, and you're right, it's in a national format. I think going forward, it is about putting it into that real context about what's important to across Cheshire and Merseyside, and therefore the action plans will actually be the really key component, and those which we can be held to account against. I think what you've got is the statutory reporting. What this board needs to do is hold the system to account for actually delivering some of those.
Thanks, Chris. A couple of comments from me. One is, firstly, about the report, please do pass on to Andrew and the team. It's a good report, it's informative, and it moves my understanding on, which is always helpful, I think. comment. In the recommendations, we're asking to approve the objectives, the four objectives. Just want to make a comment on that. And it's the last one, which is written, empower and engage our leadership and workforce. I'm not sure that I get why that's an objective that's specific enough for to turn into a strategy and a plan. Addressing inequalities overall would be better, I think, for our workforce. But is there a rationale, Chris, why it's written in that way?
They are the legacy objectives of the CCGs, and therefore we felt that it was important to show those because that's what this plan was against, and therefore we will be amending those, and I think that's why they are short term, with a view that we'll be bringing back to the next meeting or the next iteration of this report our objectives for the next 4 years. So it's just simply we've adopted the legacy CCG ones, but absolutely accept what you're saying.
But I understood you to say that these objectives will inform the 23-24 period. Well, I'd really like that last objective to be looked at, unless people disagree.
I mean, we can obviously make a change, and I think probably make it more reflective of the conversation we've had. I think following today, we'll make the change, maybe just sort of circulate it virtually to board members, if that's okay, because we've got to, subject to everything else being agreed today, we need to publish on the website. So I'd like to publish, if we publish everything else other than the 23-24 objectives, which we'll just do a sort of quick round robin to sort of firm up, and then we'll publish those later.
Thanks, Claire. So, there's a series of recommendations about noting and finally approving those four objectives, and we've heard that caveat that's going to be put on that. It remains to be said, I think, this issue presents us with an enormous challenge on where we're at this moment, both in terms of service provision as well as the people that we directly directly employ. Reporting, is this, how often will we hear about progress?
We came in November, so probably quarterly, I think.
Yeah.
I think it would be good to sort of keep it on the sort of regular agenda.
Thank you.
Thank you.
Okay. Let's go on to risk management. Claire?
Thank you. I'm going to introduce this, and yes, good. Hopefully colleagues Matthew and Dawn are going to talk through the details. So the paper today outlines our approach to risk management, including our approach to the board assurance framework, principal risks and risk appetite. It was the subject of a board development workshop a couple of months ago, maybe, but I think it really just outlines how complex a system we work in terms of the 17 providers, 9 places, and how we sort of pull together the aggregate risks at a strategic ICB level and manage that programme. So as way of introduction, hopefully I can now hand over to Dawn, maybe? Dawn and Matthew to talk through the detail, if that's okay, Chair. Thank you.
Thanks, Claire. As Claire said, there's 3 elements to the report. The first is the risk management strategy. That's been developed based on current standards and good practice. It's been subject to internal consultation within the ICB and also with our internal auditors. That's attached to Appendix 1. And then we've also pulled out the key components to illustrate how we're going to approach risk management at scale and at our places, set out some definitions, scoring and tolerances. So we're asking at this point for that strategy to be approved so that we can publish it. We're obviously well on in terms of implementing it, working with colleagues across corporate teams and across our places to identify the risks and populate the risk registers. The next element of the report sets out the format, the proposed format for the board assurance framework document that we would be bringing to you once a quarter, and the purpose of that is to record and report on our key strategic objectives, principal risks, controls and assurances to the board in respect of those controls. So the proposed format is set out at Appendix 3 and it's described in the report at Section 4. The executive team are working on the principal risks based on our ICB strategy. We're expecting to bring the first full bath to the April board meeting. And then the final element of the report is the risk appetite statement. That's the mechanism whereby the board sets parameters for decision makers across the organisation regarding the level of risk that they're allowed to expose the organisation to, and when to escalate and where to target controls. So there's a draft statement, incomplete statement at Appendix 4. That's been developed following the board development session in November. And at this point, we're asking the board to review the core statement in the centre of the appetite statement and the risk appetite definitions. Following that, we'll then seek some further input from board members, both individually and collectively, to frame the detail of the statement and to assign the specific appetites to the objectives and the risk elements. So I'll pause there and happy to take any questions. Thank you.
Thanks, Dawn. So many of us have been involved in these conversations around risk. But I think this is pretty obvious. This is one of the most fundamental plans and strategies that we've got to the effective running of our organisation and the functioning of this board. So it's imperative that we get this right. Steve?
Thanks. First of all, welcome the paper, and realise that it's the first paper to try and establish a framework and an approach and clarify our responsibilities. I think it's very strong in its analysis and its narrative around appetite, tolerance, responsibilities and the governance. But actually, I actually think that risk assessment strategies should drive organisations, not follow them. And what I see here is an approach that could be somewhat overcomplicated in a very complex world of health and social care. So my plea would be that when we come to the actual risk assessment statement, which we monitor in order to drive our business planning and our investments, it's simple. And risk assessment statements can indeed be a risk because they're overcomplicated and look like the Beijing telephone directory. It becomes an industry in itself. So I'm just asking, many corporate organisations worldwide run their whole organisational planning and strategy and decision making on less than 20 risks. Just wonder whether we could try and get the risk down. Admittedly, it's in a rather complex and changing world.
Thanks, Steve. I think there's two things that you've said in it. One is the risk appetite statement effective?
Yeah.
It's relatively short, but so I'm sure Dawn and colleagues will happy to be guided if there's any further improvement on that. And the second one is a more broader comment about how we would prioritise risks into those that must be seen at this board, and there should not be a lot of them.
Yep.
Okay, I think that's a statement, and we'll get some feedback on Steve on this, on the statement itself. Hilary?
A great report, thank you. What I'm struggling with a little bit is how do we encourage providers to look up and look out so they understand their place in this risk management system. And I say that because what I see is place, that's great, and providers will hopefully report their risks into place. But I also see the provider collaboratives and then there's individual committees. And I just wonder in that, is the double delegation? I apologise. Are we delegating? Well, are we relying on different committees, different places to report risk? And therefore, are risks coming at us from different places? And is there I don't want to use the word risk again, but is there a risk that we're going to miss?
That's half the challenge, Hilary.
Yeah, I know it's really complex. It's not a criticism.
No,
at all.
I think that
it's
is
just
the
a
challenge.
dilemma that's running around my head at the minute. How on earth do providers make sense of where they report, and how do providers make sense of what the overall system risks are and their place in that? Does that make sense?
It does, and I think that was the point I was making very briefly at the beginning in terms of the complexity of the system. As statutory organisations, they have, their own board assurance frameworks and their own risk registers. We've asked places to develop their own, some of them sort of legacy risks from CCGs and new risks. Yeah. And then we're looking to have an overarching ICB board assurance framework, and I think it's 9 principal risks, so it's not 20, but that is the complexity. And I think that's one of the reasons we're looking to introduce probably a fixed sort of short-term risk committee to sort of do some of that work, to sort of look at the aggregate and almost sort of a basket of risks. You know, what's the top ones and how does that feed down? But I think that is a challenge when you've got statutory organisations, you've got the provider collaboratives, and you've got the places, but we do need to hold that as an aggregate at ICB level, so that's what we've got to work through quickly.
And I suppose then the key question, would a provider board, a provider NEV, for example, see themselves as part of this, as part of the system risks?
Maybe that's a question for...
Maybe that's a litmus key question to ask.
We can give some comment views from Anne and Joe as chairs of the collaboratives. They do. You know, they were a part of the work that led to here. But as Claire says, we yet to work through the mechanics of how things actually happen and get escalated. I think Tony and then Matthew.
Thank you, Raj. I think you touched on one of the key things here. The establishment of a risk committee in its final challenge would be is to consider how we could operate a system level assurance framework, which is the biggest challenge we've got. Hillary's right. We're being fed in information about risks from places and providers, but that's the whole art of this, is to gather all of that, to recognise it, but to operate as far as possible as a system. So the core statement, I think, has got very close to this idea that we have an overarching system level appetite for risk, and that's the responsibility for the ICB. That should be reflected reasonably well in individual places and providers. So it gives places and providers a steer on risk. Obviously, the ICB has no tolerance for safety risks that could result in avoidable harm to patients. That would be in everybody's risk appetite, that's quite clear. But trying to operate as a system is clearly the biggest challenge we've got, and I don't think anyone's done that yet.
And it's what we bring here versus what sits within individual organisations, discussions and and back conversations. So I think we just need to maybe have that sort of extra work for this committee.
Yeah, I think it's a great piece of work so far. So.
Thank you. Right. Matthew?
Yeah, no, it's a really good question from Hilary, and one that is taxing all 42 ICBs and ICSs at the moment, and it is something as a network the company secretaries have raised with NHS England to say, you know, where has completed it really well? Well, the answer is nowhere really yet, but there are some areas that are starting to progress this and are starting to share their learning on the differences, what they're looking at in terms of an ICS assurance framework versus, you know, our corporate one as well. So I'm part of that network, and so I can bring back that learning. But go back to another point. Some of our local board secretaries from our providers are asking those questions of me and colleagues now about, you know, we're really interested to know about your risk appetite, your risks, so we can start to align, you know, the language and the way of doing it. So I think, you know, we are in a good position. You know, we've talked about the complexity. It's a little bit harder to do it with all our 9 places and our 17 providers compared to others around the country where there's only 3, for example. But it is absolutely something that we have to look at, not just the ICB, we have to look at the ICS. And there will be a role for other partners in this. There'll be a role for the Integrated Care Partnership in this, because they've got to look at that. So hopefully we can get our house in order first in terms of what we need to do to give you assurance as a board around our functions. We'll absolutely do it in parallel with the ICS conversation as well.
Thank you, Matthew. Any other comments or questions? Okay, so let me move to the recommendations then. So firstly, approve the risk management strategy as attached, Appendix 1. We've heard some comments about, let's call it the introduction of it. Yep. Approve the proposed board assurance framework report format. That's the examples in the papers. People comfortable with that? Thank you. And approve the core statement and risk appetite definitions. Steve, you'll have a think about if there's any further comments we want to give. Great, so we'll approve that. And then finally noting the work. Just a plea from me is very early on, we do need to think about the implementation of the risk management strategy in terms of how we train and develop our staff to operate it really effectively. I can see you nodding. Is that thoughts going on, Dawn?
Yeah, I mean, we're focusing our attention on the senior managers who are the risk owners at the moment and the governance leads in place, but we will be doing a more comprehensive training programme, yeah.
And just once again, Matthew, Dawn, Claire, good, loads of work underneath this. Good paper, thank you very much. It moves us on. Thank you. Claire again, ICB Prioritization Framework.
Yeah. Excuse me, thank you. So, as with the NHS, whilst everything's we know everything's a priority, don't we? But whilst everything is a priority, we do need to focus down and determine a set of key priority areas, which will be the focus of the ICB's and HCP's work in the over the coming year. So we're building a framework which will help us to prioritise our commissioning intentions, and probably as importantly, I'm sure Claire will be pleased to hear, our decommissioning intentions. It needs to be the same framework, but we just use it with a sort of a different lens. The paper sets out systematic co-design work that's been taking place over the past few months to develop a framework, the initial focus of which will be on our health inequality challenges, but we're hoping it will be sufficiently robust that it can be adapted for all elements of commissioning decisions going forward. You'll remember last month I presented the interim HCP 5-year strategy, which was developed in partnership with all of our stakeholders and wider system players. We acknowledged that there were too many "we will" statements, so an HCP prioritisation analysis has been pulled together and is being used in a series of workshops over the coming week in advance of the HCP workshop on the 7th of March. So for sort of assurance over the next week, we'll be meeting with CHAMPS, so public health colleagues, the Primary Care Forum, the 2 provider collaborative medical directors and directors of strategy, to help us identify if the work and findings that we've done to date resonate, so that we've got the right conversation to have at the HCP. So I think that's positive in terms of co-design. I did want to mention, Raj, that EDI runs through this in terms of the prioritisation framework. So the development of the final prioritisation framework is near conclusion. We've got some simple refinement to do with weightings and various other things. And there'll be then another set of workshops, probably wider this time, to include the voluntary sector, Health Watch, the ICB Clinical Effectiveness Group, directors of adult social care and children's services, to start to use the framework to determine how our health inequalities monies will be invested in the first place. And I think we had that conversation earlier in terms of health inequalities, and I think it's a good place to start in terms of making sure we target that in the right place. So section 6 of the report summarises the next steps in a very detailed and thorough co-design piece of work, which hopefully will help us systematically make evidence-based decisions on our commissioning.
Thank you, Claire.
Thank you.
Can I take any questions or comments, Graham?
I have 2 comments, if you don't mind, and I think they're one's contextual and one's governance. So we are often given priorities by government to implement. So this is not an invitation for us to change those priorities that we are given. And sometimes we are given those priorities in quite a constrained way. Even so, there will still be decisions for us to make on those priorities. So we were told to expand the number of operating theatres in Cheshire and Merseyside. We weren't given a choice about that. If we didn't do it, we wouldn't have got the money. But having got the money, we then had to decide where was the most effective point. And I could give you a whole range of examples. So the principles and the techniques in here are the really important thing. But then that leads on to the governance point for me, and it's really important that we're explicit that this technique or this process should apply to work that is undertaken on our behalf by the provider collaboratives. So, for instance, if we take this point about new operating theatres, we actually ask the provider collaborative to run that process for us, to determine that process, but really important that they do it in observance of the principles of this.
Thank you, Graham.
Thank you. And that's hopefully the outcome, Graham. That's why I think some of the engagement with provider collaboratives over the next week or so is particularly important.
Thank you.
Thank you.
Steve?
Well, welcome the paper, and I mean, clearly the priorities must link to the 4 core objectives of the ICB. That's why we're here: population health and care, tackling unequal outcomes and access, productivity and value for money, supporting the broader social and economic agenda. So, but I think there's a danger here. I'm sorry to be coming across a bit like I want to be over simplistic, but if everything's a priority, nothing often gets done. You have to prioritise the priorities, and I certainly hear what Graham has said about ones given by NHS centrally. But I'd like to think this will help us develop a forward plan. In local government, we're obliged constitutionally to provide a forward plan, so we know what's coming up. It has to be flexible, because sometimes things just arrive. And it helps us in so many ways with this organisation for briefings. I mean, Paul and I operate in democratic organisations. People want to know what's going on here. And we often say, what's coming up? And so far, we can't tell them that. So if there's this link to the development of a published forward plan, so we can plan ahead, so we know what's coming up for this board, I think would be very, very helpful.
Thanks, Steve. Good.
Thanks, Steve. So I think this absolutely underpins the work that Claire referenced in her update in terms of the ICB's joint forward plan, which will have that developed in draft by the end of March, final document by the end of June, which will get, hopefully, subject to PERDA and all the sort of complications and timelines, be signed off by the 9 health and wellbeing boards. But absolutely, I think with a joint forward plan, we'll then have an annual plan, which the board will hold execs to account for, and vice versa. So I think that will be supported by this. So thank you.
Thank you. Thank you, Steve. Warren?
Thank you, Chair. It was just to get a sense of where the crossover will be between this panel and the role of the ICP in terms of determining and shaping those prioritisations. I think there's a little bit of duplication potentially there in terms of where the driver for that decision making comes from.
Do you want to give a view?
So, I mean, the workshop for the HCP, I mean, the interim strategy is an HCP strategy. So I think we need to, as an ICB, it's our part, what part we play in delivering the objectives of the HCP. This prioritisation tool, as Graham said, we want it to be sufficiently robust so it can be used for all elements of the ICS to make it complicated with the next year. So I think in terms of prioritisation, you've got the interim strategy, but this will, through the workshop, I think, hone down. And as we said previously, we have to prioritise the priorities. And I think the HCP priorities will hopefully focus on sort of the wider determinants and the work programme and the health inequality agenda.
I think there is a concern, isn't it, that there could be a mismatch between how the HCP works and this board works in terms of that prioritisation. My thought on this, specifically on Warren's point, is I think that the prioritisation framework could help bring it together. But it does mean then the HCP needs to have a significant engagement on this framework to make sure they're comfortable with it. And we'll need to achieve that somehow, won't we, through those workshops?
Yes, I mean, we've got the sort of sessions over the next sort of week or so to sort of hone things down, and we'll come to the HCP workshop in I think it's the 7th of March, isn't it? And hopefully that will then help us as an ICB set our sort of health and wider care priorities. But we do need to, I mean, this is iterative. You know, this is the first time we've had a prioritisation framework, or will have, for the whole of the system, and it's really complicated. So we're going to have to test it out, I think. And the proof will be once we, hopefully, with our health inequalities money, we use the framework, we use the HCP as the board to allocate some of those funding.
Okay. So, can I sorry, Paul, go ahead.
No, thanks. It was just to add to your comments. I think the involvement of the HCP in this is particularly important, and to get that link established, exactly how it is going to work in the future. Just to say, particularly on item 510 about the prioritisation panel, I think a little bit naive in some senses to I see that you want all 9 areas represented, and to have a different one. I think who picks those is really important as much as anything else, and I think it needs a little bit of thought, and I think very much input from the HCP on that as well.
Okay. Can I just say, I think that hopefully just shows the spirit of co-production that this prioritisation framework has been developed with. So happy to look at that.
Well, I'm all for that spirit.
Okay.
I think Paul's cautioning to make sure we consult widely on who the representatives
I think so, yeah.
are.
Okay.
Thank you, Paul. If we turn to the next steps, Claire, I can't see in the next steps how the framework comes, when the framework comes back to the board. It doesn't, and it should, I think.
It should. Let me just read that. I'm going to say if we try and bring it back for April.
Yeah, that's good. Thank you. And I think I've understood it. It'll be work in progress. We'll refine it, and maybe 23-24 is a development year for it.
Well, we need to use it in anger, I think, in terms of some of the, particularly the health inequalities monies, and then I suppose working with the other parts of the system to encourage them to use it for some of their decisions. But I think it's as important, as I said before, in terms of our disinvestment and decommissioning, because otherwise...
Sorry, let me put my question in a better way. We need to do some BDSA cycles around it to make sure it's effective.
We need to start using it, don't we? So let's, I think, basically from April, we need to crack on
and evaluate and review.
Yeah.
Okay. Are people happy to support this way forward? Really interesting work. Thank you, Claire.
Okay.
And Claire again.
Yeah, okay, thank you. So this paper is to update the board on the transfer of delegated commissioning responsibilities for general ophthalmic and primary community and secondary care dental services from NHS England to the ICB from April 23. We've completed a PDAF, a pre-delegation assessment framework, which has been underpinned by a safe delegation checklist as part of our due diligence for that transfer of services. The 2022 Health and Care Act tasked ICBs with commissioning and oversight of NHS services, and the future delegated responsibility of all primary care services was covered as part of that act. So the board will remember we took on the responsibility of community pharmacy in July last year, and for assurance we undertook the same PDAF pre-delegation assessment framework and safe delegation checklist process as we have done for dental optometry. So sections 2 to 3.2 detail the oversight and due diligence that we've undertaken, and we've kept the System Primary Care Committee informed at all stages and had detailed conversations about the services that we are taking on, and with dentistry in particular we are having tomorrow our second deep dive in terms of sender-receiver organisations. So those of us in the ICB who are taking on responsibility for the services have all the detail of that. So section 3.3 and 3.4 lists the services that will transfer to us from April. I think it's important to note that this isn't just primary care dental services, as in high street dentists. It's the full end-to-end pathway of services for dentistry. You can see in 3.5 some of the issues and priorities that we will be inheriting. And I think, Alison, you said about access absolutely is a priority. We're all aware of the high-profile access issues with dentistry at all stages in the pathway, and we'll be inheriting those from April. So we have to get our house in order to take on the responsibility for those and all the activity. But we mustn't ignore the pressures and challenges in optometry too. Obviously, Adam's talked about community pharmacy, but I think this paper is purely about the delegation, but we do know about the pressures in pharmacy, and we have those conversations through System Primary Care Committee. So access to primary care services is a key priority. It's part of the planning guidance, so we need to take note of that. You can see that the commissioning budget for the ICB will increase by just less than 280 million, which includes a full year effect of community pharmacy in 2023-24. but there are risks within that budget, both digital and contractual overspends, and potentially high-profile underspends has been highlighted in the press in dentistry over the last few days. So we're working very closely with our colleagues in NHS England to be absolutely clear on the budgets before they transfer over, but looking at the opportunities that some of those will give us. So the paper's there to note the work that we've done. Hopefully that provides assurances, and we do that through the System Primary Care Committee. And I'll happy to bring back further updates on all well, we'll bring in something back on primary care next month, but in terms of delegated services, I can bring something back on maybe a 6-monthly basis.
Thank you, Claire. Any questions or comments? Graham?
So, Claire, I think you've gone halfway there to answer this, and it's part of the due diligence process. But are these numbers in Table 313, are they the current budget, the current expenditure, or are they something else? So are they proposing to transfer to us the current dental budget with its underspend as well?
I've asked that.
Because I believe we could do a lot better at this.
Yes. And that's part of the due diligence, and that's one of the challenges we've absolutely clarified.
It's transferred at allocation rather than spend.
Thank you. Thanks, Graham. So let's go move to the recommendations. There's three issues to note, and one to approve, which is the work undertaken in date to relation to the delegation to General Alnwick and Dental Services. I'm happy to support that. Thank you.
Thank you.
Go on to Cheshire and Merseyside Health and Care Partnership Chair's report. I'm delivering that. It's really pleasing to see how, through the offices of Louise and support by Claire, how the partnership board is coming together. There's a workshop happening a couple of weeks' time. That's the culmination of a lot of work in terms of the shoe leather of bringing people to understanding on the committee together to work with common purpose. But it's going to be a test for us about whether that common purpose and cohesiveness that we seem to have is actually going to come out in terms of an agreed set of priorities. Reports there on the last committee. I'm happy to take any questions or comments on that. No, otherwise there for noting really. Thank you. Graham, Liverpool Women's Services Programme update.
Well, no, Chair, it has my name against it because we put these papers together whilst Chris was on annual leave. But Chris is our lead for this.
I was told that. Yeah. Apologies. Yeah.
So I don't want to steal that.
Chris.
Yeah, thank you, Chairman. So the purpose of this paper then is to provide an update to the board about the progress in establishing a programme to take forward the recommendations in the Liverpool Clinical Services review, which were to address the clinical sustainability challenges affecting women's health for people who access the services provided by Liverpool Women's Hospital. And these services are provided for people in Merseyside, Cheshire and beyond. The recommendations from the Liverpool Clinical Service Review were considered at the January ICB board meeting, and the objective was to realise the opportunity for greater collaboration between acute and specialist trusts to optimise the clinical pathways. So the paper highlights the background to the review over the last number of years. There's been significant public interest in the future of the services delivered by Liverpool Women's Hospital. The trust is valued for the quality and breadth of its general and specialist services at the current Liverpool Crown Street site, and it has amassed a petition of 60,000 people since 2016, of which was presented to the ICB board in our January meeting. I'd like to highlight that the ICB board is committed to openness and transparency in the implementation of this programme, and will involve and engage with a wide range of stakeholders and interested parties, and including the Safe Liverpool Women's Hospital Group. And a number of us from the board met with a small representative of this group on Monday evening to listen to their comments and questions and concerns, and my view was it was a beneficial meeting for all that attended, and something that we'll continue to engage with when moving forward. So the programme governance arrangements is that a subcommittee of the ICB board is to be established with a role to oversee the development of a future care model, to ensure the best possible care for women and babies. And the subcommittee will include members from non-executive directors, executive directors, representative from NHS Trusts and dependent services, from Health Watch, and also patients with lived experience. And the process for how we determine that membership has yet to be clarified. So the committee will report following each of its meetings, of which the first meeting is due to be held next week, which will agree the draft terms of reference. I think that was all I wanted to highlight from the paper, Chairman. Happy to take any comments or pass to colleagues around the table.
Thanks, Chris, and in particular, thank you for meeting our colleagues from the public who are passionately interested in this topic, and your assurance that will continue, so that's really good. Any comments or questions? Are we comfortable with direction? Okay. Thank you. If we could move to the subcommittee reports, Tony.
Shall I start again, or can I just continue? No, just two items to pick up from section 2, and it's important to note the work that Chris has done. The local maternity and neonatal system now reports monthly to the committee and is as a standard item on the agenda. It's really important that they get fully integrated into the ICB. It's a really big step forward for us. The second thing to note is the work already done by the subcommittee on identifying risks. That's in section 3. It's only a draft at this point, but it's important that we keep focused on it, and the helpful report we've had today is going to drive further work in identifying quality risks going forward. The last thing to ask you to consider is that there was a thorough review of the harmonisation of policies, which was referenced in Graham's report last month. Just asked the board to endorse and approve formally the harmonisation of those policies. Further work will be needed, and it will come to the committee in due course of the remaining policies. Thank you, Chair.
Thank you, Tony. So I know this committee has a very full agenda and is very well attended, and it takes a considerable amount of time for the members to go through this, go through the reports, which is of vital importance and support to this board. So thank you for that. Can I take any questions or comments? Good, thank you. We move on. Erica's not here. Is there anybody who attended the Finance Committee?
I can do it, yeah. So the paper is obviously there with the content of the conversation that we had in the meeting on the 25th of January. We talked at depth the month 9 financial position, and we had an update as well on the organisational change process that the ICB is currently undertaking. We reviewed the terms of reference, and set out as an appendix to this paper that you have in your pack is an amendment to the terms of reference which we're proposing. So the two things then for me to ask of the board is just to note the contents of what we discussed in the meeting, and to approve the updated terms of reference, of which there was just one change in the appendix.
Thank you, Claire. A hugely important committee to us. Members of the board happy to approve the revised committee terms of reference? One change. Yeah. Okay. Thank you, Claire. So, closing remarks from me. Another good meeting, really good conversation and discussions. Thank you very much. As usual, our excellent comms people will summarise the board meeting and make sure we will circulate widely that information, and all the papers are on the website. Before I close the meeting, I just wanted to say a particular note of thanks to the exec team. I know you've only had a couple of weeks between the last board meeting to produce all these papers, and we've seen some really, really high quality papers today. So enormous thanks to you all, because I know it takes a lot of time and effort to get these things right, and of course thanks to your teams. Date and time of the next meeting is 30th of March. Thank you very much, and thanks to the members of the public bearing with us and listening to what we had to say today.